Welcome to the new and hopefully improved unRemarkable labs. We're discussing rheumatological testing today with one of my colleagues, Dr. Angelo Gaffo. Angelo, introduce yourself, please.
I'm Angelo Gaffo. I am the Rheumatology Section Chief in the Birmingham VA, and I'm Associate Professor in the Division of Rheumatology in the University of Alabama at Birmingham. Thanks for inviting me.
And we have some wonderful residents with us. Julie.
I'm Julie England. I grew up in Texas, went to med school at Texas A&M, and now I'm a second-year resident at UAB.
Malika.
Hey, I'm Malika. I'm an intern at WashU. I'm from Richmond, Virginia, and did my med school at Virginia Commonwealth.
Sam Kelp.
Hi, my name is Sankulp. I'm also a second-year resident at UAB. I did my med school in India and came here for residency.
And our fearless leader, Natasha.
Hi, everyone. My name is Natasha. I'm a second-year resident at UAB, originally from Memphis, but did my undergrad and med school at UAB. So I will get us started. Dr. Gaffo, we have a 26-year-old female coming to see a primary care physician. She has a past medical history of asthma for which she takes her albuterol inhaler just intermittently. She's coming in just complaining of fatigue and some vague myalgias and arthralgias that have been going on for the past 4 to 5 months. She said she feels fatigued, and no matter how much she sleeps, she's still kind of tired, and she's noticed that it takes her a little while to get going in the mornings. And so when she's presenting to a primary care physician, what workup would you recommend? And feel free to ask any further history.
Yes, this is where you need to conduct a very hypothesis-driven, I think, review of systems. For the issue of the arthralgias, the natural question would be, the distribution and the pattern, symmetric, not symmetric, which areas are most painful. It's different if you have back pain with hip pain than when you have a small joint pain. The question of the fatigue also is important. There are common things being common, depression, sleep apnea, depending on her body habitus, things that need to be explored necessarily. And if you are rapidly kind of suspecting an inflammatory or autoimmune disease, you start going through a quick review of systems, which include rash, ocular symptoms like eye pain and redness, ulcers in the mouth or in the nose, the shortness of breath, of course, dyspnea, cough, gastrointestinal symptoms for the suspicion of associations with spondyloarthritis or inflammatory bowel diseases, and all urinary symptoms, abnormalities in quality or quantity of urine production. So I would try to spend the next 5 to 10 minutes gathering most of this information.
Yeah, so we can just kind of go through review of symptoms, kind of head to toe, I guess. So she's endorsing some headaches that she has. They usually go away with Tylenol. No shortness of breath, chest pain, no ulcers that she's noticed either in her mouth or nose. She does have some redness of her face. She wouldn't call it a rash, but she feels like it comes on sometimes in the heat or if she eats spicy food, kind of around her cheeks. No abdominal pain, constipation, diarrhea, no urinary symptoms that she's noticed. In terms of the arthralgias and the joint pain, she says it's bilateral, kind of her knees, her ankles, as well as her elbows and wrists. But that being said, she also says she just feels sore all over kind of all the time.
That's very useful. So there's a component of symmetry. It certainly tends to involve preferentially the peripheral joints. You mentioned that most of that review systems seems to be negative or unremarkable, with the exception of this facial reddening. When I see facial reddening or erythema in people, in women in particular, rosacea is more common than the malar rash of lupus, but certainly that's the distribution that you would expect for the malar rash of lupus. With for rosacea, you need to pay attention to pustules, and the distribution tends to be different. Also, seborrheic dermatitis and other conditions can be similar, but you look for the malar involvement preferentially for the malar rash of lupus, with a sparing of the nasolabial fold. But it's an interesting hypothesis. So she could have an autoimmune disease characterized by arthritis and this usually photosensitive rash that in the typical distribution of a malar rash. We would like to see her laboratories, very basic labs, because you want to make sure that she's not anemic, explaining part of the fatigue. And if she's anemic, you would like to see the characteristics, if it's iron deficiency, or is that then could lead you to the questioning about her menstrual periods, if they are heavy or not, or is a microcytic anemia more of anemia of chronic disease, or normocytic anemia of chronic disease. And certainly her basic chemistries and her inflammatory markers will give you a first guidance towards this could be an autoimmune disease.
Agreed. And this is just a question I have personally. So when I see a young female coming in with joint pain and swelling, kind of the top 3 things I would say on my differential, fibromyalgia is always on there, rheumatoid arthritis and lupus, and then kind of differentiating. Is that kind of the things we should be thinking about, just common things being common?
Yes, I will throw in there the family of spondyloarthritis in there, which include maybe psoriatic arthritis in this context. You can see ankylosing spondylitis in women too. It's less common than in men, but that tends to it can locate in the back preferentially, but it can also involve peripheral joints. But psoriatic arthritis is certainly something that can mimic a lot of what you are describing. So I will also consider that in the big family of lupus RA, psoriatic, and pain amplification syndromes, what we kind of call fibromyalgia. Osteoarthritis, that is the other big arthritis, would be much less common at this age, unless there is a significant risk factor.
So Angelo, one of the things that I think I notice is that many students and residents are uncomfortable with how the physical exam might help in this situation. So the physical exam is a diagnostic test. So could you explain the physical exam you would do on this young woman, and how that might point you in one direction or another, or give you more focus on pretest probability that you're dealing with a rheumatological disease?
Yeah, the physical exam certainly would be quite comprehensive, and with more attention to the joint exam certainly. But I will spend a minute looking at her eyes, making sure that there's no eye redness, and that the pupils are equal, and there are no synechiae or irregularities, because that will point you towards uveitis that can be associated with a number of autoimmune diseases. I will look inside her mouth, usually looking for the ulcers that are located in the hard palate, in the top of the mouth roof. Although sometimes aphthous types of lesions can be present in the buccal mucosa and can point to other more rare diagnoses like Behçet's disease and similar conditions that can also have arthritis and fatigue. I will listen to the lungs somewhat carefully. I always pay attention to crackles, and especially to dry crackles. If you hear dry crackles, immediately your mind starts going to scleroderma, myositis, and diseases that can present with interstitial lung disease. Lupus and RA too sometimes. The heart exam can just be paying attention to a common findings of heart failure that could explain fatigue, but that's not very high in our differential, a primary heart failure, but I will probably proceed this way. I would like to look at her muscle strength and make sure that she's not clinically weak in a way in which I would suspect myositis. Now, when a patient is in pain, sometimes the physical exam, the muscle strength evaluation can be hindered by a painful effort. But if you gather that this person is not weak, really, that can firmly resist gravity, that reassures me that probably she doesn't have a significant clinical myositis. And as a rheumatologist, I usually finish with my joint exam so I don't forget the rest, especially in cases like this that where you have to where you don't know still what you're dealing with. I usually try to hit 28 joints, which include the 10 joints in the hands that the MCPs and PIPs. I look at the distal ones when the suspicion is for osteoarthritis sometimes. The wrist, elbows, motion of the shoulders, and the knees. Now, that's when I suspect rheumatoid mainly, but in this case, probably I would still move the hips. I will probably feel for tenderness in the sacroiliac joint area projection, and also feel for pain located in the spinous processes in the back. It's different, a little different in a case like this because you still don't know what you're dealing with. The differential is quite wide, so your exam needs to be more comprehensive. So that's how I would approach it. I will probably also palpate her pulses and make sure that at least the radial pulses are symmetric and present, and the pedal pulses are symmetric and present. What I have seen a few times in my career, young women with this type of presentation, they end up having Takayasu arthritis with pulse deficits, and yeah, those are the points that I will try to hit.
Could you be even more specific when you do the MCPs and the PIPs? I assume you're looking for synovitis, and how do you assess that?
I usually put pressure in the joints when palpating them, and that way you elicit the joint pain part. The description for physical exams of the joints is that you have to put enough pressure to blanch your own nail bed when you touch those joints. And when assessing the swelling, you usually feel them from the sides and from the top and bottom, and you try to feel that. Everybody will have a little bit of a sponginess around the joints, small amounts, but patients with swelling, you will feel that that there is a larger degree of again, sponginess or enlargement of the joint that you can press on. Usually it's painful. In larger joints, it's associated with a degree of warmness too. And you also, in larger joints, you evaluate the range of motion that can be quite limited in cases in which there is a significant joint effusion.
Okay, Natasha.
Yeah, so this patient, she did have tenderness in her wrist and then pretty much kind of diffusely across all of her joints. No swelling that I appreciated, no bogginess, no synovial hypertrophy. At this point, because she was kind of tender diffusely, I ended up pressing on her muscles, which were also tender, raised my suspicion a little bit more for a pain amplification syndrome. She did have some swelling though in her bilateral knees, which ended up confusing me a little bit more. But essentially she was tender to palpation fairly diffusely, which, I knew didn't necessarily rule out autoimmune disease because fibromyalgia and pain amplification syndromes tend to coexist fairly frequently. She had good range of motion in most of her joints. Her wrist, her hands were a little bit stiff, as well as her knees, but she was able to move them pretty well. Her strength was 5 out of 5. I didn't see any redness or swelling in her eyes. Dr. Gaff, I don't think I did as good of an exam as you would have, but those were no crackles in her lungs and no murmurs or anything in her heart.
Now,
So Angela, what should she do now? Should she get labs? And if so, which ones?
I would probably always do some laboratories, basic labs looking for anemia again, and like kind of low-hanging fruits for fatigue. You want to make sure that there's no metabolic abnormality, probably explaining her fatigue to a degree, unlikely in someone this young and without a prior comorbidity. But inflammatory markers could be helpful here. C-reactive protein and sedimentation rate to kind of, if you are really suspecting fibromyalgia and the patient comes with very normal inflammatory markers, you could argue that the stopping there is appropriate. If now Natasha is describing swelling in her knees, and that probably would make me concerned enough that you could do further testing. But if this were somebody with a very normal joint exam and just a lot of tenderness, out of proportion on palpation of muscle areas, I probably would say that with normal inflammatory markers, I probably would argue that no more testing is needed. But no, there's at least some knee swelling that concerns me.
So you're willing in many patients to just get a SED rate and a CRP, and if those are normal, say we shouldn't be going down the inflammatory pathway.
Yeah. Now, normally, Bob, by the time these patients get to me through electronic consults or real consults, they already have had more than that.
Right.
And if it were my call, they probably, with a good exam, good history, you could stop with a C-reactive protein and a CRP.
Good. Natasha, tell us the rest of the story.
So I did get basic labs. Her BMP was actually unremarkable, Dr. Santor. I'm sorry. Her CBC was remarkable for a mild microcytic anemia. On further history from her, though, she does have fairly heavy periods and soaks through multiple pads a day. Platelets were normal. ESR, CRP were normal. I did end up getting just a rheumatoid factor, CCP, and an ANA. All of those were negative, at which point I called her and told her that she most likely does not have any autoimmune disease, and actually started her on duloxetine to help with some of her pain.
Yeah, that sounds like many consults that I get through the electronic system in the VA, and that is more or less how we manage. Now, the good part here is that when patients, now sometimes we make mistakes. Now I call patients like these, oh, you don't have, most likely there's not an autoimmune illness, and months or years down the road they show up with something else and I was wrong. So that's the beauty of having a good primary care system to follow them. Those patients don't necessarily need to be followed in a subspecialty clinic, but when they are attached to a good primary care doctor, that if something happens, they can be retested and referred back. That is the right way to treat these patients.
And I do have, oh, sorry, go ahead.
Go ahead.
I have a question. So I tend to see either on the inpatient side or even in clinic patients that'll come and say, oh, I've had an autoimmune workup before and I had X antibody that was positive. Is it fairly common for patients to have non-specific symptoms fairly early, and then, like you said, years down the line end up developing autoimmune disease? And that's not necessarily, maybe something that we missed, but something that just hadn't fully manifested yet. But they can have positive antibodies that were only found because somebody just ordered everything.
It's certainly, we've seen it a fair amount of times, but the denominator of patients who end up having being tested or having mildly elevated autoimmune tests and some vague symptoms, and that eventually that doesn't evolve to anything, it's probably much larger. Now there is a difficult gray zone of patients that say have fatigue, arthralgias, myalgias, and the autoimmune testing is equivocal, let's call it. It's one of these ANAs of 1/80 or 1/160 and nothing else. And a fair amount of times these patients are tried on hydroxychloroquine and tested for clinical response. And clinical response is when it's absent, sometimes you stop the drug and you focus more on management of pain amplification of fibromyalgia. But sometimes even that clinical response is not completely clear. So a patient feels that it's helping some. So there is again a very kind of difficult to determine gray zone and how to manage. Sometimes to follow these patients for 2 or 3 years, nothing else happens. The clinical response is kind of equivocal or not solid, and then we stop the medicine. And most likely you didn't have an autoimmune disease, and so there is a lot of uncertainty in certain patients. Yeah.
So, Sandkelp, do you have any other questions or comments?
I think I was muted. Yeah, I think there was a great discussion. Like I especially like the physical exam format that was suggested by Dr. Gaffo. I think that 28 joint rule is really good to remember, because I feel like whenever I do like rheumatologic exams, I tend to miss certain joints or tend to overlook certain joints. So I think that's a good rule to follow and use for physical exams. And then yeah, I feel like the utility of ESR and CRP and basic lab testing in a case like this where you don't have any particular defining symptoms is also pretty interesting.
Let me just tell you, Dr. Center knows this very well. There are people that I respect and love who hate inflammatory markers because because it's true that they are imperfect tests. I think they are you need to be very mindful of their limitations. So in someone with a low pretest probability for autoimmune disease, and normal inflammatory markers can reassure you more, but probably in someone who in which the concern is larger, like in this case, like Natasha was mentioning, I had this nagging feeling about the knee swelling. And so would I have stopped just with a normal cellular and CRP? I'm not sure. I told Bob initially yes, but after remembering that the swelling in the knees, I thought, well, maybe she needs more testing just in case. So it's a lot of again the context and being mindful of the value of the tests.
Malika.
Yeah, I thought that was a really helpful case in learning how to approach patients. I feel like, this is not an uncommon scenario for clinic patients. And just kind of hearing your approach to the physical exam and not forgetting things like looking for uveitis and the pulses. I feel like, that's not something I would necessarily remember to do in a patient with that coming to that patient.
In first exam, also go to the feet, because I always forgot to mention this. Psoriatic arthritis lost involves the feet. Sarcoidosis also can sometimes in young people likes to go to the ankle. So the joint exam needs to be a little bit more comprehensive in that first evaluation when you still don't know what you're dealing with.
Julie?
So this is coming, I guess, from kind of a primary care perspective and dealing with patients that have, every time you see them, they're complaining of pain. And so it was helpful to me to kind of talk about when to stop, like you say, completely normalized joint exam and reassuring inflammatory markers, you can kind of stop there. I guess my question is, what if you go to the next step and get like the CCP and the rheumatoid factor and maybe something's like a little bit positive, or like when is it okay to stop? Like when you've gone further in the workup,
Yeah, that's a very good question because it's a very common problem. You know, every patient goes to your practice looking for an answer. They want to feel better. They also many want to know what they have. And sometimes it's pretty unsatisfying for the patient for you to tell them that they have fibromyalgia or they have or they have osteoarthritis. They are expecting something more tangible. So sometimes it's, especially when the tests are equivocal or kind of again low positive, it's very hard to explain this to the patient that much more likely than not this is a false positive, that is not translating into any autoimmune condition, a meaningful autoimmune condition. And sometimes when we ourselves have that question, we are using more a musculoskeletal ultrasound to try to answer that. Say you have someone with joint pain, joint swelling, you're not sure. Sometimes this person has big hands and kind of fat digits, and you're not sure about the swelling. The ANA is like 1/80, and the rheumatoid factor is 22, upper limit of normal 20, and so sometimes in that context, we send the patient for a MSK ultrasound, which can look inside for synovitis and erosions, and it has limitations too. Sometimes you don't know how to interpret a very tiny amount of hyperemia. But yeah, if it's completely normal and the MSK ultrasound is full of osteophytes, you can reassure the patient more that you are not seeing inflammation. Of course, you have to remember your other differential diagnosis with carpal tunnel, with just plain osteoarthritis and things like that. But in those cases, we are using MSK ultrasound. Now, would I go to a second layer of very comprehensive and expensive autoimmune tests and something like that? Probably I wouldn't, because that's where you kind of, it's not going to help anyone. And like the odds that the answer is going to be in one of those extended autoimmune panels, it's very, very, very small. So I probably wouldn't go there.
Thank you very much, Angelo. Natasha, you get to wrap it up.
Yeah, so the reason I chose this case is because it's, like kind of Julie was saying, as a primary care, we see a lot of these patients in clinic, and it can sometimes be hard. And now that I'm married to a rheumatologist, I am a lot more careful about who I refer over and try to manage more so I don't have to hear about it at home. And so I think it all comes back to being deliberate about what you order, and don't order something you don't know how to interpret, or if you're not expecting, if someone's not having dry eyes, dry mouth, then don't order an SSA, SSB. And so I think this was a great discussion. Thank you guys all for joining us.